pregnant woman Rh negative and husband Rh positive, then it's a high risk pregnancy. Indirect comb test is done on the first antenatal visit. If it is negative, then it's a case of unsensitized mother, and if it's positive, it's Rh isoimmunized pregnancy. So coming to the management of unsensitized Rh negative pregnancy, if indirect comb test is negative on the first antenatal visit, the indirect comb test has to be repeated at 28 weeks, and if it is negative, give 300 micrograms of anti-D or 1500 international units of anti-D. It will give protection to this pregnancy. This is called antepartum prophylaxis. And do normal vaginal delivery plus early cord clamping at 39 to 40 weeks. Again, if newborn is Rh positive, do direct comb test. If direct comb test is negative, give 300 micrograms of anti-D to mother. This is postpartum prophylaxis and it will give protection for the future pregnancy. This postpartum prophylaxis can be given 72 hours to 28 days after delivery. So coming to Rh isoimmunized pregnancy, on the first antenatal visit, if indirect comb test is positive for a Rh negative pregnancy with Rh positive husband, then first we have to check antibody titer. What is isoimmunization? So if the baby is Rh positive through placenta, if Rh positive blood reaches the maternal circulation, there antibodies are formed against Rh antigens. First IgM followed by IgG. This will cross the placenta and reaches the fetal circulation, causes hemolysis of the fetal blood. So in this case, first we have to check antibody titer. There is no use of giving anti-D if there is Rh isoimmunized pregnancy. First check the antibody titer. The critical titer is 1:16. If the titers are less than 1:16, that is 1:2, 1:4, 1:8, repeat titer every 4 weeks. If titer starts increasing, then repeat titer every 2 weeks and deliver at 37 to 38 weeks of pregnancy. So here only monitoring plays role. And if the titer is greater than or equal to 1:16, that is 1:16 or 1:32 or 1:64 and like that, so it's a critical titer. Look for fetal anemia. In any case of fetal anemia in obstetrics, remember peak systolic volume of middle cerebral artery Doppler should be done. So if peak systolic velocity of middle cerebral artery Doppler shows less than 1.5 MOM, repeat every 1 to 2 weeks and delivery has to be done at 37 to 38 weeks. If it is greater than or equal to 1.5 MOM, then it's a case of fetal anemia. Chordocentesis has to be done to know the hemoglobin of the fetal blood. If the hematocrit of the fetal blood comes greater than 30%, repeat hematocrit every week. If it is less than 30%, you have to check the gestation age. If it is greater than or equal to 35 weeks, delivery has to be done. Less than 35 weeks, intrauterine blood transfusion has to be given. And here, if the hematocrit is greater than or equal to 30, repeat it every week and antepartum fetal surveillance has to be done and delivery has to be done at 37 to 38 weeks. If it is a non-sensitized Rh negative pregnancy, delivery has to be done at 39 to 40 weeks. And if it is a sensitized pregnancy, you have to monitor all these parameters and try to deliver the baby at 37 to 38 weeks. If not, that is, if there is severe fetal anemia, then 35 weeks. Delivery has to be done at or above 35 weeks. In unsensitized pregnancy, early cord clamping has to be done, and in sensitized pregnancy, delayed cord clamping has to be done. Because here, as there is fetal anemia, delayed cord clamping helps to acquire extra blood from the mother. So, Rh isoimmunization causes immune hydrops if the hematocrit of the fetus is less than 15% and hemoglobin less than 5 gram percent. Overall, most common cause of hydrops is non-immune hydrops, and in the non-immune hydrops, the most common cause of non-immune hydrops is of serious pathology, followed by chromosomal and followed by infection like parvovirus B19. So, coming to other important points, usually fetal-maternal hemorrhage after delivery is less than 4 ml. That is, for this fetal-maternal hemorrhage, anti-D of 300 micrograms or 1500 international units is sufficient, but sometimes there will be increased fetal-maternal hemorrhage, like in trauma, delivery, instrumental delivery, twins, IUD, manual removal of placenta and all. So then we have to calculate the anti-D. Anti-D calculation done by Kleha-Bettkis test is a quantitative test. Reagent used is citric acid phosphate buffer, and the principle is fetal hemoglobin is resistant to acids and alkalis. It is similar to Singer's aptitude test or Singer's alkali denaturation test, which is a qualitative test that differentiates vasa previa from placenta previa. So, for every 30 ml of fetal-maternal hemorrhage or 15 ml of fetal RBC, 300 micrograms of anti-D is enough. That is 300 micrograms of anti-D or 1500 micrograms of 1500 international units of anti-D neutralize 30 ml of fetal-maternal hemorrhage or 15 ml of fetal RBC. For every 1 ml of extra fetal blood that enters, for every 1 ml of extra fetal blood that enters the maternal circulation, 10 micrograms of extra anti-D is needed.